All right, we are now recording, and now I will get your screen back. Play. Did that show back up on your screen?
Yes, and it says recording.
Oh, perfect.
Okay.
Hey, Dr. Woodward, have a nice time talking to the kids. I need to step out just for a quick moment to make sure I have another recording that's saving in my other room, so I'll be right back. So
sounds good.
Go ahead and start, and when you're ready to go to your next slide, I'll be here for you.
Okay, sounds good. So I'm an anesthesiologist. My name is Dr. Kristen Woodward. I'm actually boarded in two different specialties. I'm boarded in general pediatrics, and I'm also boarded in anesthesiology. I work for a very large practice in town. Our practice just merged about 3 or 4 years ago, and now we have a huge practice, and we cover everywhere from Castle Rock to North Denver. My prior practice was South Denver Anesthesiology, which I was a member for years, and now our practice name is US Anesthesiology Partners. So next slide.
There you go.
I am a graduate of Cherry Creek High School. I went to college at the University of California, Santa Barbara, right after graduation from Creek. I went to medical school at Tufts University School of Medicine. I then completed my pediatric residency in Arizona. I worked for a year as the chief resident and worked in the pediatric emergency department. Following that, I completed my anesthesiology residency at the University of Colorado Health Science System. And I was 33 when I had my first real job. So I had, after high school, 15 years of education. There were no gap years when I did this as there are now. So many of you probably don't necessarily know what anesthesia is. So the description of anesthesia is it's really the loss of sensation with or without loss of consciousness. And what that means is typically when people think about anesthesia, they think about people maybe having their appendix out, having general anesthesia. But we can make parts of the body completely numb. So that would be the patient's very conscious, but their arm or their lower half of their body is completely anesthetized. Anesthesia is also a temporary drug-induced coma when you're having general anesthesia, and really it means the lack of feeling or sensation. Next slide. So why do we need anesthesia? Well, there's looking back in the history books, Fanny Burney was a poet in the 19th century. She wrote a very descriptive paper that described when she had a mastectomy without anesthesia. The description she gives is she was given 2 hours prior to her surgery when she would be having the procedure. She was given 1 glass of wine, and during the procedure, 7 men had to hold her down. Next slide. She let out a continuous torturous scream that did not abate even after the surgery was completed. When the wound was made and the instrument withdrawn, the pain seemed diminished. The air that rushed into those delicate parts, it felt like a mass of minute but sharp and forked poignards that were tearing the edges of the wound. She screamed for 3 hours and lived another 29 years. Next slide. So again, we talked a little bit about amnesia, which is the loss of awareness, but we also have analgesia, and that is pain control. So anytime you have an injury, you're having surgery, we can't only do amnesia, we also have to provide anesthesia and analgesia. We can get possible paralysis of the musculature and limit responses to the autonomic nervous system. Next slide. So it's interesting because anesthesia is a fairly young specialty when we look at various specialties across the board. Surgical specialty has been around for thousands of years. We've known that people have done drill holes in a person's head for hundreds of years and treated injuries and traumas, but the practice of anesthesia is relatively young when we're looking at various specialties in medicine. Next slide.
I don't want to get drilled in my head.
Does not when you're awake. No. From the 18th century well into the 1840s, physicians and chemists, they really experimented with various anesthetics, and some of these you might have heard of. So nitrous oxide, which is laughing gas. You may have had that as a small child during a dental procedure. Ether, carbon dioxide, these were really used without success. Mm-hmm. Horace Wells was a dentist, a well-known dentist who traveled to Boston and attempted to demonstrate that a tooth extraction could be painless. Next slide. So, and then around the same time, William Morton was also a dentist. He started using nitrous oxide. He took a chemistry class at Harvard and discovered an organic solvent, which was called ether, and that can make a person unconscious and really not aware during a procedure. Next slide. In 1846, Morton administered an effective anesthetic to a young man, Glen Abbott. He had a very vascular tumor that was removed from his neck by Dr. John Warren, and this was the first described anesthetic that was used with ether. Next slide. They used, this was interesting, this was the ether inhaler, and it was developed by William Morton. Again, this is one of the first instruments that was used for anesthesia during a surgery in 1840s. So I have a very, my practice is very varied. We work all over the hospital, and that's what really drew me to the practice. So we are perioperative physicians. We take care of patients of all types. We take care of pediatric patients. We take care of pregnant women. We take care of very old people, very young people, very sick people, and very healthy people. What we do is we really aid surgeons and other practitioners to prepare people for surgery. We're airway experts. We're resuscitation experts. We offer pain control both in acute and chronic pain clinics. We're really patient safety experts, and we're experts in physiology as well as pharmacology. Next slide. So again, we work all over the hospital and actually outside of the hospital as well. So there's some outpatient clinics that we work in. We work in the operating room, obviously, obstetric suites, pediatric hospitals, chronic pain clinics, the radiology suite, I'm there very often, gastroenterology suites, ambulatory surgical centers, intensive care units. And today, actually, I was an anesthesiologist providing anesthesia for patients who had electroconvulsant therapy for severe depression and bipolar disorder. So our practice is varied. It makes it very interesting. Every day I do something different. I travel around to several different hospitals. So it's an exciting career, I must say. Next slide. Our workspace is very complicated. I went from pediatrics to anesthesia, and sometimes it can be a little bit intimidating walking into an operating room for the first time. There's always an anesthesia machine, and then we have an extensive cart that's full of different medications and airway tools and things that we use in case a patient needs additional help during a procedure. The thing I love about the practice is we see immediate results. We kind of have a little intensive care unit happening right at our workspace. So we give a medication, we see a result. In comparison to other physicians who have to write an order, and then the nurse administers it maybe 30 minutes later. So we do these things kind of immediately. Again, it's like a little critical care unit right in the operating room. We're there to really optimize patient outcomes, and we're definitely the safety experts in the hospital. Over the past, let's see, I've been in practice now about 20 years. We've seen dramatic reductions in anesthesia-related deaths. We've seen a decrease from 1 in 10,000 in the early 1980s to less than 1 in 250,000 today. And that's really because of our monitoring tools that we have. A colleague of mine who is since retired, when he first started practicing, we didn't have something as simple as a pulse oximeter, something that is obviously routine today, used in the hospital. And you may have, seen this even when you've been at the pediatric office. If you've had a respiratory illness, they might have checked your pulse oximeter. Again, technological advances like the pulse oximetry and tidal CO2 monitors. A lot of times we have a difficult airway, and the first detection that we're in the trachea instead of saying the esophagus, if we aren't able to see the trachea, is the end-tidal CO2 monitor. And this has drastically reduced mortality in anesthesia. So we often are called to cardiac arrest in the hospital. The reason that we are airway experts, along with I would consider an ear, nose, and throat physician as an airway expert as well, is we control and take care of patients' airways every day, multiple times a day. So a lot of times this isn't something that people in the hospital are necessarily comfortable with. The first skill that you learn when you're doing, say, basic life support is how to mask a patient with a mask and provide oxygen, and then we proceed that with intubating a patient. Oftentimes we're called to help with the intubation because it's something we do every day, and it's, again, something that people aren't necessarily comfortable with. Difficult airways are challenging. Pediatric airways are the most challenging and can be. Pediatric patients born with airway anomalies can be very, very challenging. And this is what the training provides us with, is sort of, we see thousands of routine airways so that when we don't have a routine airway, we know how to take care of the patient safely. And next slide. We use many tools every day, especially airway tools. Probably the most exciting for me on this is the video laryngoscope. This is something that was developed in my practice time, so within the past 10 years. It sort of revolutionized, I think, our practice to some degree. We have fiber optic scopes that we use and various types of blades and laryngeal mask airways as well to take care of patients. And this is a pediatric, so I did a pediatric residency, so I do pediatric cases often. Pediatric patients are classically challenging, not only because of their airways, but because of their physiology. They desaturate much more quickly than an adult patient. And looking at this picture, this is a patient with Pierre-Robin. It's a congenital anomaly. And if you look, they don't have very much of a chin. It's a very micrognathic picture, no chin, very difficult to intubate this patient because you're not going to be able to have a good visualization of the vocal cords. Next slide.
Ooh.
Yeah, this is a trauma, and we see a lot of, they call us to the emergency department if someone has any facial trauma. Again, this is going to be a very challenging airway because of the trauma that's occurred. There's airway is distorted, there is secretions and blood, and this is a patient that ultimately might need a tracheostomy. Next slide.
What happened to that patient, can I ask?
So that was a patient from Denver Health, and that, I believe, was a motor vehicle accident.
Wow.
Mm-hmm.
Oh, unbelievable.
I know. So touching base, now with pediatric anesthesia, there's a fellowship after the anesthesiology residency. It's 1 or 2 year fellowship. The anesthesiology residency is 4 years, so 1 year of a internship year like surgery or internal medicine, and then 3 years of anesthesiology. Pediatric patients or pediatric anesthesia, there are some pediatric anesthesiologists that have done a pediatric residency followed by an anesthesiology residency. But pediatric anesthesia is very cool because there's a lot of even subspecialties from that. So you can do neonatal anesthesia, fetal anesthesia, pediatric cardiac anesthesia, pediatric pain. And then of course, I trained with many anesthesiologists who then worked in the pediatric intensive care unit.
Were those your 2 kids?
They were, but that was a while ago.
Great looking kids you got.
Yeah, thanks. Again, pediatric anesthesia is challenging. They have challenging airways. We don't put IVs in many pediatric patients because the pediatric patient doesn't want to have an IV. If you've ever had an IV, it's painful. It's like a shot to the child. So we often put that in after they're anesthetized. And then they can have congenital anomalies as well that sometimes aren't picked up until they're undergoing their procedure.
As a parent who had a young child who had surgery, I appreciate you doing that. You know, they gave her like a lollipop.
Right. That helps
Boom.
with, right, helps, I know. So that child, that picture prior was it's a double bubble sign with the abdomen, and it's a child with pyloric stenosis. This is something you can see in kids. They're born without an outlet of their stomach, and they proceed to get very sick and dehydrated, and that is a unfortunately common surgery that we do in kids, young children, babies.
Wow.
This is just, again, describing some other anatomic variations that why make pediatric patients more challenging when you're trying to place the breathing tube. And the reason a lot of times people need a breathing tube, or babies or children need a breathing tube during surgery, is we have to control their breathing. There are some surgeries that we do that we don't have to control their breathing, and in that regard, we can place a mask airway once they're asleep and the patient can breathe on their own. They inhale and exhale the gas anesthetic. We were talking about ether. We have different anesthetics now. But for a lot of the surgeries, we do have to paralyze the patients. And if we have to paralyze the patient, we have to control their breathing. And that's why we have to put in breathing tubes. And this just kind of is leading more into the physiology of the pediatric patient, that they can be a little bit more challenging. Their blood pressure is more dependent on their heart rate. Unlike an adult who has a strong heart muscle, their blood pressure is more dependent on their stroke volume. So their heart is strong, but on a pediatric patient, their heart muscle isn't as strong. So they're very dependent on their heart rate. So you want to see a fast heart rate in a baby or a child. Their respiratory muscles are more prone to fatigue. And that's why if a baby, or you've had a sibling who've had that cold called RSV, it's a very common cold in a older child or an adult, but in a baby, they can get very, very sick, and their muscles can fatigue, and they can not take deep breaths and will need oxygen, and they have a higher oxygen consumption. So all of these things make them a little more challenging under an anesthetic and surgery. That also makes them a little more challenging when they get an illness like a cold or a respiratory illness that wouldn't necessarily be that problematic for an older child. And next slide. This is an airway emergency that we see under anesthesia. It's not very common in adults, but it's much more common in kids. And I was talking earlier about visualization of the vocal cords. This is kind of the view we see when we are putting a breathing tube in. The upper left picture is looking at an open vocal cord, and the lower is the closed vocal cords. So this is the doorway to the trachea via the vocal cords. This is where we would place the breathing tube. So pediatric patients' airways are much more sensitive towards either irritation, sensitivity towards the breathing tube. And what can happen is these vocal cords can acutely close right when you take the breathing tube out. It can also happen as they're waking up from anesthesia. And this can really be an emergency, because if your vocal cords are closed tightly, you're not getting any air, you're not getting any oxygen, and so you desaturate very quickly, and it can really lead to a respiratory arrest quickly. So this is something we're always on the look for, especially in taking care of pediatric patients. Fortunately, we're all very trained in this. We know how to treat this, and even though we see it, we take care of it quickly. And again, another picture of the vocal cords with the picture on the right showing the closed vocal cords, which would be laryngospasm, and the one on the left is the open vocal cords.
Wow.
The treatment of laryngospasm, something we do often, we can just continue to provide 100% oxygen, do a jaw thrust, which is a way we manipulate the airway, provide positive pressure ventilation, deepen the anesthetic. And then also we provide muscle relaxation because the vocal cords are controlled by muscles. So if we can relax those muscles, we can get the patient oxygen, which is what we need to do. So people often ask me, why did you do a pediatric residency first? You know, I did 7 years of residency. That seems so long, and it is, but I would do it over again. I felt like the pediatric residency made me a better anesthesiologist. I would do everything again. I really thought when I started my residency after medical school that I was going to do pediatric critical care, and I got interested in anesthesiology through that. And I'm so glad I did, because I do feel like the practice of anesthesiology is interesting, challenging. I'm always learning new things. And like I said, every day is different, and it's very, very rewarding. So we see immediate outcomes, and that's something that really drew me to the practice of anesthesia.
Awesome.
And the next slide. So I wanted to touch base. I know everybody's been living through this, and it's had a huge impact, certainly on students and your current schedule, on teachers, trying to get back into the classroom. And the coronavirus pandemic absolutely had a humongous impact on the healthcare system. So in March, when we started to see the beginning and the spread, especially through Colorado, my practice was absolutely impacted. It was impacted both in the type of care I was providing patients, but it also had a huge impact on the practice in general. So in regard to anesthesiologists and surgeons, Governor Polis shut down all elective surgeries. So, and this was shut down for about 5 to 6 weeks. And that was really important because we were concerned about, I'm sure you heard in the news, the number of ventilators that were available to patients who might get sick, the amount of patient protective equipment that we had available to healthcare providers in the hospitals. And then we didn't want anyone to come in for an elective procedure to get sick. So we saw our volume, or our work volume, decrease by over 80%. But we were used in other areas of the hospital, which was interesting as well. So I'll go to the next slide. So this is a picture of PPE that we were using. Now, anesthesiologists were determined, you know, healthcare providers determined, you were hearing this word essential. So I like to phrase that we were really the essential physician, because we were put on intubating teams. We were put on teams that were used across the hospital to put central lines in, to put arterial lines in, to intubate patients. And intubating a patient with coronavirus is extremely high risk. So you only want very experienced people doing this. So it was a little bit of a challenge, because you worried about, well, am I going to be putting my family at risk? Am I, you know, I'm willing to put myself at risk, but I'm going to come home and expose my kids and my husband. So a lot of sort of ethical challenging things we were going through. But at the end of the day, I absolutely feel comfortable. As we've seen that the numbers have really been low here in Colorado, they came down with what we were doing and wearing the masks, and we're doing elective procedures now, extremely comfortable, not worrying about exposing individuals in the hospital, not worried about exposure to myself, because we have plenty of PPE, and I felt like our protocols have been extremely up to date and beneficial towards not only the patient, but also to the staff.
I would say I would not recognize you on the photograph with your all of your protective.
No, I know. Do I have any other slides, or is that it? That's it.
That's it.
Yeah.
So Dr. Woodward, what we'll do is I have a way of embedding this, and if kids have any questions, I'll email them to you, and if you have the opportunity, would happy to have you respond. So thank you so much for doing this much stranger way of this class. I know that last year you guys got bumped. I think you got pulled into surgery last year.
That's right.
And so, but I appreciate you so very much. And
thank you.
And hopefully a year from now, we will be live in person.
I hope so.
Well, thank you again for your time,
Thank
and
you. Good to see you.
you as well. And so as soon as I hit stop, I think that's going to end our call. So I appreciate you very much. Thank you so much. I hope,
Thank you
stay
so much.
safe, my friend.
Yeah.
Thank you. Bye-bye.